minutes?
Yes, great.
I see Kun Veeravan from Siriraj Hospital having joined the panel session today.
Ah, choice.
We have Joyce from WHO Kenya Country Office logged in as well. Hi, Joyce. Yeah, the numbers are ticking in. More and more participants seem to be joining the panel discussion.
Yes.
That's good. Nick, should we kickstart? You're on mute.
Yes, I think we should. I think we should. In fairness to people that have come on time.
Okay, great. Welcome everyone to today's online session titled "Identifying and Responding to the Needs of Vulnerable Groups for Pandemic Preparedness and Response: Are People Living with Non-Communicable Diseases Key Populations." This is an official side event of Prince Mahidol Award Conference 2022, contributing to a conversation aligned with the theme, "The World We Want: Actions Towards a Sustainable, Fairer, and Healthier Society." Let me now introduce myself. I'm Geeta Sabharwal, UN Resident Coordinator for Thailand. I will be co-moderating the session along with Nick Banatwala, who heads the Secretariat for the UN Interagency Task Force on the Prevention and Control of NCDs. This session has been organized by the UN Multi-Partner Trust Fund for NCDs and Mental Health under the UN Interagency Task Force on the Prevention and Control of NCDs. The task force has been very active in Thailand over the past few years, jointly led by the Ministry of Public Health and the UN country team, with participation from across line ministries, civil society, and academia to comprehensively respond to NCDs. The UN Multi-Partner Trust Fund, established last year by WHO, UNICEF, and UNDP, is designed to catalyze government action in low and middle-income countries for NCDs and mental health through a one UN approach. We would like to thank our co-host, International Health Policy Program Thailand, for co-organizing this session with us today. The objective of this session is threefold. First, to understand how to integrate the prevention and control of NCDs into country-level pandemic preparedness response agenda. Second, to explore global, regional, and domestic financing for addressing NCDs as part of the PPR implementation. And third, to discuss the role of a catalytic fund in strengthening resilience by preparing us better for tomorrow's challenges. The session is privileged to have distinguished experts and practitioners of global health who will speak about NCDs in the context of pandemic preparedness and response and global health security. Let me introduce you to our distinguished panelists. Let me start with Dr. John Arne Rottingen. Dr. Rottingen is the Ambassador for Global Health with the Ministry of Foreign Affairs of the Government of Norway. Our second panelist is Dr. Thasapon Thamanarangsi. Dr. Thasapon is the Director, International Health Policy Program with the Government of Thailand. Our third panelist is Dr. Raji Tajuddin. Dr. Tajuddin heads the Division of Public Health Institutes and Research, African Center for Disease Control and Prevention, and is based in Addis Ababa. Our fourth panelist is Cecilia Ho. Cecilia is the Program Advisor for HIV Health and Development at UNDP here in Thailand. And our fifth panelist is Tom Bolicki. who's the Director of Global Health Program, Council on Foreign Relations based in Washington, D.C. A very warm welcome to all our panelists. We look forward to a lively discussion and welcome all participants to include questions in the chat box as we go along. We will start with 2 rounds of questions for each of our panelists, and thereafter we will have 30 minutes for an interactive Q&A. Let me pause here and hand it over to my co-moderator, Nick. Nick, over to you.
Well, thanks very much, Geeta, and Happy New Year to you and Happy New Year to everybody attending today. This is my first kind of formal event of this year, so I guess it probably is for many of us. So it's a great privilege to have this and exciting to be here. And let's hope we generate some energy which will drive us forward into this new year. You know, a lot has been written and said about NCDs in COVID-19, and Geeta's very clearly articulated the objectives for today. And we all know that many of those people with NCDs and risk factors are those that have suffered most under this pandemic. And indeed, if you go back and look at previous pandemics, you see a similar picture that's happened with SARS and MERS. And no doubt that's going to be the same with future pandemics. I think it would be incredibly naive to think that once we're through with this, we're not going to face something else in the foreseeable future. So therefore, people with non-communicable diseases clearly are a group that we need to be thinking about when it comes to pandemic response and pandemic preparedness. And indeed, when we think about global health security, it means now starting to think ever more about what this means for people living with non-communicable diseases, and starting to think about targeted prevention and control measures. And we know that so much of non-communicable diseases is, of course, preventable. Now, the thing that is increasingly of interest is this term that people use around key populations. And it's been something that's been used widely in the area of HIV and AIDS to prioritize policies and actions amongst key, if you like, vulnerable groups. And so it's interesting as part of this discussion and thinking about some of the objectives that Geeta has outlined, start thinking about where this term could be, should be, is appropriately used or not appropriately used when it comes to start thinking about NCDs and COVID-19, when people are thinking about pandemic preparedness and response. So it's really exciting to have this group of distinguished speakers. Please start using the chat to ask any questions, and let's get this lively discussion underway. Back to you, Geeta. You're on mute, Geeta.
Sorry. Thanks, Nick. Let's start with the first round of questions for our panelists. Each panelist will have 3 to 4 minutes for the first round. And Tom Bollecki, we are starting with you. You've been writing on the importance of addressing NCDs prevention and control as part of assuring global health security. And you recently wrote a paper on the interaction between NCDs and COVID-19 and other pandemic threats. To provide some evidence for framing this discussion today, could you give us a brief synopsis of your key findings and the arguments you make in the paper? Over to you, Tom.
Great. Thank you so much for having me. It's a pleasure to be with this group and at this event today. And thank you for the conference organizers for accommodating this discussion. So I've been asked to speak a bit about the link between NCDs and the COVID-19 pandemic based on a piece that it's available on CFR.org. I'll put it on in the chat in a moment. I think it's clear that COVID has not stopped the toll of other diseases, most especially NCDs. And NCDs prior to the pandemic have been a leading source of premature death and disability, killing an estimated 15 million people between the ages of 30 and 69 each year. During the pandemic, even amidst the terrible toll of COVID-19, NCDs still represent the top 3 leading causes of death globally. So that has not changed. But there's been something more fundamental that ties to pandemic preparedness that's been revealed in this pandemic. And that is the unhealthy feedback loop that exists between NCDs and outbreaks of emerging infections. And it works in 3 steps. First, NCDs have made the toll COVID worse. In particular, the high prevalence of obesity, diabetes, and other NCDs have been a major contributor to outsized death tolls from COVID-19, particularly in the United States, Europe, and Latin America. NCD burdens, and by this I mean greater numbers of death and disability from NCDs, correspond with certain countries' higher death rates per capita from COVID-19. That becomes even stronger when you look at specific NCDs or health-related threats like obesity. It's important to emphasize this is actually not true for other classes of diseases. It is not true for infectious diseases. It is not true for injuries. There's no correlation between the burden of those and the burden of NCDs. It is also not true for most of our metrics of capacity. It is not true in terms of universal health coverage. We found no association between deaths from COVID-19 and assessments of universal health coverage or many of the leading metrics of pandemic preparedness, such as the joint external evaluation and the scores that people have obtained on that. So that's the first step. NCDs have made COVID worse. The second step is COVID has also made NCDs worse in return. And the way that has occurred is the need to respond to this immense toll of the pandemic and its economic consequences is shifting resources, both internationally and domestically, away from NCDs and health systems. So global aid for NCDs, as everyone on this conference likely knows, was already quite low, 2%. It has declined. According to our assessments, it has started to decline in response as a share of overall global health spending. It has started to decline in response to the pandemic. There is some evidence that that may also be happening at the national level as countries move resources, understandably, to address the COVID threat. The risk, though, is this leads to the third step, which is further underinvestment in NCDs makes future pandemic threats worse also. NCD risk factors such as obesity, smoking use, tobacco use prevalence have been linked to more severe outcomes from other pandemic threats like influenza and Zika. So in conclusion, we are seeing the legacy of underinvestment in NCDs reverberate through this COVID-19 pandemic. But the story can be different for the next pandemic. There's still time for that. Yet the singular focus on COVID-19 and the traditional notions of global health security in general ignores this emerging negative feedback loop that exists between NCDs and emerging dangerous pathogens. It is only by breaking that loop through an integrated approach of addressing the COVID-19 pandemic and the global NCD burden generally is imperative to mitigate the threat from this pandemic, but also future ones. And let me stop there and look forward to all the questions.
Great, thanks very much indeed, Tom, for that. Geeta and I are going to share some initial questions with the panelists in the first instance. I'd like to thank you, Tom, very much for that, and move over to Raji. Raji, welcome. I know you joined us a little bit later, and Geeta did introduce you earlier. I'd be very interested to understand a little bit more from your organization, Africa CDC, which has been a key resource for countries in the region during the COVID-19 pandemic. And I'd like you to perhaps share with us a little bit about the experience of countries in Africa with regards non-communicable diseases and COVID-19. So welcome, Reggie.
No, thank you. Thank you so much, Nick. Well, let me start by apologizing for joining you late. We have some ongoing construction outside of the African Union Commission, and we've had some internet interruptions since morning. So having said that, the African Union Commission and the Africa CDC by extension, even long before the COVID-19 pandemic, we've taken NCDs as something very, very serious. Because in 2013, when our head of state and government met and launched our socio-economic development agenda, that's the Agenda 2063, the Africa we want. The aspiration 1 goal 3 of that agenda clearly, stated on the need for us to begin to address both the NCDs and the communicable diseases. And of course, fast forward, Ebola came, then Africa CDC was set up. So by some of what I'm trying to say here is that for us at the African Union, at the Africa CDC, NCDC has always been on top of our agenda. Now, with the onset of COVID-19 pandemic, of course, that role became much more significant, and we begin to pay more attention to that. We do have a division that is looking at NCD at the African Union Commission and at the Africa CDC. Now, with the COVID-19 pandemic, we set up what we call the African Task Force for Coronavirus. And part of the work of this task force was also to look at how do we ensure that those essential health services, including NCDs, continue, to be run in such a way that because of attention being drawn or drafted towards the COVID-19 pandemic, some of these issues are not neglected. And of course, as the COVID-19 pandemic itself begin to evolve, we begin to see what the previous speaker, that's clearly articulated. That's the vicious circle between the NCDs and the COVID-19 pandemic. The fact that those people with chronic NCDs are at risk of coming down with the COVID-19 disease. And apart from being at risk of coming down, they're also at risk of severe and critical illnesses. And of course, we also know on the flip side of that as well, that the people with COVID-19 also don't do well at all when people with NCDs don't do well at all when it comes to COVID-19. So it's an issue of interrelationship between the COVID-19 and NCDs. And of course, what we have seen coming out of most of our member states is the fact that because of the COVID-19, there's a drop in the care for those patients with COVID-19, patients with NCD. There's a drop in terms of access, to healthcare by those people with NCD. There's also a drop in terms of care because most of the people who are supposed to be taking care of NCDs by way of either running the clinic or taking care of the inpatient, running the coronary care unit, they have all been drafted towards responding to the COVID-19 pandemic. And last but not the least, we have also seen shift in resources, financial resources and other resources away from NCDs towards the COVID-19 pandemic. And what did we do as Africa CDC? First and foremost was to issue a guideline to all our member states that look, in view of the COVID-19 pandemic, please, the essential health services need to continue to run. Number two, we made frantic efforts to meet with all the different stakeholders here, including the funders and those who are running those programs that have one thing or the other to do with NCD, on the need for them to continue to run those services, on the need for them to continue to allocate enough resources so that the NCDs does not suffer. So we did that. And one of that Africa CDC did was also to issue some sort of guideline that will allow member states, especially the aspect of mental health, which is a core component of NCD, to make sure that the mental health does not suffer, because we know that with the onset of the COVID-19 pandemic, we see a lot of, what they call gender-based violence, which is part of mental health issues, especially in the southern part of the continent. And Africa CDC did issue a guideline to that effect. And even for the frontline responders themselves, we know that a lot of them suffered mental breakdown because of the chronicity of the COVID-19 pandemic. So we continue to issue guidelines to support our frontline responders. And last but not the least, we also roll out some sort of a training, that will equip our frontline responders with what we call psychological first aid, so that they're able to stay fit, and those who are struggling, we can have a way of identify and recognizing them early enough and be able to institute appropriate management. So these are some of what we did as Africa CDC, in terms of the non-communicable diseases vis-a-vis the COVID-19 pandemic. Over to you, Nick.
Thanks very much indeed. Very helpful and very clear. Geeta, back to you.
Thanks, Nick. And thanks, Raji. I like the way you framed those 4 points that you made about establishing the Africa Task Force for Coronavirus, the guidelines for countries in Africa for ensuring financing, mental health, ensuring that mental health remains a priority by governments in Africa, and finally, the frontline workers and the support that they need and the capacity building support that you provided to frontline workers. Extremely helpful. Let's move on to Cecilia O. Cecilia, we've heard about what research is showing about the interrelationship between NCDs and the virus, coronavirus, and what countries in Africa are experiencing. You worked on HIV for a long time, but the concept of key populations programming approach has made real gains in combating the HIV epidemic. What is your view on applying the key populations lens to planning and programming for NCDs in the context of pandemic preparedness and response? Over to you, Cecilia.
Thank you very much. A good day to everyone, and thank you, Geeta and Nick and all the organizers for this, what I think will be a fascinating webinar. Just to start with a caveat, I've worked on access to medicines issues in the context of HIV, obviously, but my focus has been more on innovation and access policy issues. I'm also new to the NCD field, so this is an area where I hope my colleagues at UNDP will, jump in with their experience and expertise where I'm lacking. But just to maybe answer the question that's been put to me, I think there are probably a couple of points that I can put forward to kick off the discussion. In terms of the key populations framing for HIV and its whether that lends itself to NCD planning and programming, perhaps 3 points to make. First, the question would be whether or not that's been useful within the HIV context, and if so, how? And then what are the lessons that have been learned in terms of the HIV response and key populations framing? And then I think finally, the sorts of strategic opportunities that could arise in terms of using the key populations framing for NCD response. So whether that's been useful in the HIV context, as we all know, the HIV response has evolved over the past, I'd say 40 years. I think last year, 2021, was the 40th anniversary of the first reported case of, what is now known as the AIDS. And the early days of the AIDS epidemic, I think we may all remember, was defined by illness and certain death until the first antiretroviral treatment was approved in 1987. But it's been a long road to the people receiving ART now, to those early days. But has that been a good experience in terms of HIV response? I think a number of statistics from UNAIDS will bear testimony that there has been great gains. We know that there are probably about 37 million people globally living with HIV as of 2020. But as of 2021, in June, we have about 28 million people with access to antiretroviral therapy. And what we see also is that new HIV infections have been reduced by 52% since the peak in the late 1990s in 97. AIDS-related deaths have also been reduced by 64% since the peak in the early 2004, I think. And so what have been the lessons that we can learn from HIV programming? if we cast our memories back, I think the initial focus of the HIV response was on testing, treatment, and care. For example, the WHO's, I would say, groundbreaking campaign, the 3x5, was to provide access to 3 million people by 2005. That seemed like a long and tedious journey at that time, but we're there. But I think there is now strong recognition that epidemics like HIV cannot be ended without attention to key populations in all epidemic settings. And by this, we mean that there needs to be an addressing of the social, the legal, and cultural barriers to accessing treatment and other health services. And that is consistent with including, or the inclusion and participation of, various parts of the populations affected by HIV in policy development, health governance, and programming. And I think the concept of key populations have helped to do this. But the one thing that I think we might want to look at from HIV programming is that there isn't a single definition of key population that applies for all countries. I think UNAIDS stresses that it's important to ensure that countries have the flexibility to define the specific populations that are key to the epidemic, and the response is based on the epidemiological and social context. I think the Global Fund too looks at key populations and notes that there is, probably difficult to have a common definition of key population or populations across a spectrum of different diseases. But what the Global Fund does is to use a 3-point criteria, which looks at epidemiology, whether the group or the population faces increased risk, vulnerability, or burden, whether or not the second point would be whether or not they have reduced access or restricted access to relevant services. And then the third criterion would be whether or not the population or the group faces human rights violation or disenfranchisement or social or economic marginalization. So I think that is something that we want to keep in mind if we're looking at key populations framing for an NCD response. But what are perhaps the strategic opportunities for a key POPs approach to NCD response, especially in the context of pandemic preparedness and response? In my view, I think a key populations framing can provide greater focus and recognition for people living with NCDs. And I think it can also help to shape and inform the needed responses. I think Tom pointed out that, we're probably at a very pivotal point for NCD response. Obviously, COVID-19's put a spotlight on the issue of NCDs. And I think we're perhaps at a fork. The situation could remain where we continue to have high levels of NCDs and continued acceptability, inadequate financing. And even though NCDs have led to worse outcomes in this pandemic, I think we are still not seeing adequate recognition for, I believe, what Tom called the unhealthy loop between NCDs, COVID-19. Could the KP or key population framing help us move action towards a more radical improvement in terms of action and investment for NCDs? And I think that's something that we can think about in positive terms, that this could be a public and a political approach and messaging that might help in terms of helping to move the needle. And I think in terms of looking at access, can a key populations framing, especially if it's coupled with an explicit rights approach, move towards closing some of the NCD treatment gaps? I'd say a number of NCD treatment gaps. We know that the opposite happened during the pandemic, but I think it's been said already, COVID-19 is not yet over, and this might be the opportunity for us to prepare for the next one, and whether or not key POPs framing might bring us the strategic and the political and the public movement towards something that's different. And I think there's also a question of access to treatment consideration. We know that the pandemic has exposed global inequalities. Vaccine inequity obviously is a key one. And I know that this is going to be an issue, not just for COVID-19, but also for NCD responses. Right now, low and middle income countries are not just looking at the challenges of an effective vaccine rollout, but also the need for consolidated and sustainable approaches to access to diagnostics, treatment, and vaccines. And therefore, security of supply and domestic manufacturing may be on the agenda for many LMICs. So the question would be whether or not a key POPs framing for NCDs might bring greater attention to access to treatment. And I think that's, a strategic opportunity. Just an aside, we all know that 2021 is the centenary of the discovery of insulin, but we also know that access to this life-saving drug is much, very inadequate for people living with diabetes in low and middle income countries. We know that only half of them in LMICs have access to insulin, and in Africa, I think this is even worse, 1 to 7. So again, I think using a key population framing might provide us strategic opportunities. I think finally, whether or not using the key populations framing, this was a question that my colleague asked me, would that raise questions from the HIV community? I think that's a difficult question, but I think given that we know that there are all the links between NCDs, comorbidities, NCDs and HIV and the key populations, perhaps this shared approach or the shared terminology might move us towards an integration of both the NCD and HIV agenda. And to me, that would provide us, greater strategic opportunities to pivot the NCD response to something that is, greater than what we're seeing now. And in addition, I think the reality is that we have a situation where people are living with multiple chronic conditions. We know people living with HIV have a higher risk of cardiovascular disease and certain cancers. People living with TB are also more susceptible to diabetes and so on and so forth. And perhaps the answer is integrated care. And again, using the key populations framing might provide us some approaches and strategic winning points in this context. So in short, I think maybe a few more questions than answers, but I hope that's enough to stimulate some discussion. Thank you.
Great, thanks very much indeed, Celia. We'll bring together some of your points along with Regis and Thomas and the others at the end of this first round of questions. But Geeta, back to you. No, it's not. It's for me to continue. Apologies. Yeah. So on to John Arne. Welcome, John Arne. You're a leader around the area of pandemic preparedness and have been on the front lines of the global response to COVID-19. I would be interested in your thoughts on following up from Cecilia's comments around the inclusion of people with NCDs in pandemic preparedness and response. How should those institutions tasked with global pandemic preparedness start dealing with this issue that we've heard so clearly about the links between NCDs and COVID-19?
Thanks, Nick, and thanks for the opportunity to be a part of this panel. I think when we are thinking about the relationship between pandemic preparedness and which key populations or groups, in a way, we need to have first in mind, we need to consider different dimensions of risks. And in this context, I would say there are 3 dimensions. One is that who are most at risk when it comes to becoming infected. The second, who are at most risk when it comes to getting severe disease if infected. And then finally, as we have seen in many contexts, who are at most risk when it comes to the impacts of the public health and social measures, the lockdowns and so forth, the school closures instituted to control the spread. And my point, I guess, is that those risks are a combination of both biological, medical, social, and psychological. And they are, of course, not either or. It's often a combination when it comes to all those three different types of risks. And we need to have that all in mind. So we therefore need to include NCDs as well as social determinants of health in the discussions and the planning of the mechanisms and infrastructure at both national, regional, and global level when it comes to how we govern and finance, I hope, a revised, a better, updated global pandemic preparedness and response approach. So these efforts so far in the COVID-19 pandemic have often not been integrated, I think it's fair to say, even if lessons from earlier epidemics should have taught us to actually do that, as Tom also alluded to in his introduction. I've seen that WHO has recently launched an evidence brief on the social determinants of health and health equity in the context of COVID-19. And I think that also clearly has documented that COVID-19 has affected people unequally because of unequal pre-existing health, like NCDs, but also in unequal living and working and social conditions. So disadvantaged population groups in general have borne the greatest burden of the epidemic, either when it comes to becoming infected, how ill you are when you are infected, and also what the impact of the public health measures have been on those populations. So equity must be prioritized in building back fairer, and also when we prepare better for future pandemics, as we know they will come. So building country capacity for NCDs prevention and management is therefore a necessary part of a pandemic preparedness and response sort of regime, and also of strengthening global and country resilience. And countries, especially both, low-income countries, lower middle-income countries, will need to support, external support to build these core capacities for prevention and control of NCDs as a necessary part of their pandemic preparedness efforts. So in strengthening health systems and PPR, we must ensure that all risks are considered, the three risks I mentioned, and that we need to complement and strengthen these collective efforts. However, the big question is how to structure this, how to implement it. As we know, there are discussions now on establishing a financial intermediary fund at the World Bank that can mobilize additional resources for pandemic preparedness capacities, both at national, regional, and global levels. Increased and sustainable funding is needed, we all know that, and these additional resources should also be additional to official development aid and be mobilized from a framing of global public goods, because we all benefit from stronger global health security. And investing in prevention is, as we know, far more cost-effective than responding to a pandemic. However, this also means that such additional funding should not crowd out domestic funding that countries should be responsible for mobilizing themselves, but rather ensure that, as we know, the global collective positive externalities for better preparedness, if all countries prepare better, that they are internalized as benefits also in countries by incentivizing for increased domestic funding for healthcare and population health, so both prevention and care. So this also speaks to how additional international financing should be implemented, given the need to see preparedness as an integrated, as several speakers have said, integrated and in a way an emergent property of a resilient national health system. Financing should be channeled through existing mechanisms and entities at all these different levels. So my point is that increased international financing for NCDs in the context of preparedness and pandemics will therefore also need to be a part of reforming mandates, responsibilities of existing entities. And I should say that these discussions have not fully started, but we will be important in the coming years. And I think we should use the sort of coming out of the pandemic and the recovery we all need to see as a way to actually have those discussions and think about what are the best structures. Thank you.
Thanks, John Arnie. Very helpful. And you've actually, set the whole context of international financing very, very well. Let's move on to Dr. Thasapon. Dr. Thasapon, my question to you is that Thailand is one of the founding strategic partners or the multi-partner, sorry, let me come to the multi-partner trust fund question a little later. But before that, Dr. Thasapon, we know that Thailand has been a leader in innovative approaches for NCD prevention and control across the region, and in fact, even globally. What, in your opinion, are the major challenges and gaps that countries face in responding effectively to the risks that are posed by the burden of NCDs on future pandemic threats?
Thank you. Thank you, Gitar, Nick, and thank you to all organizers. And good morning, good afternoon, good evening to all. Call me Meg. In short, I have a very tongue twisting name. Yep, NCD and COVID-19 is just like slow and fast tsunami come together. We always think about, okay, we want to address one battlefront at a time, but in the real world, it is inseparable. It come together, and many speakers before me already addressed these relevance of these two tsunami altogether. But let me flash back before we have this COVID-19 pandemic. In Thailand, we are quite proud of our health system in many ways, in terms of foundation, in terms of institution and transformation. In terms of foundation, we have quite a good primary healthcare system. We have quite low out of pocket. Let's say we have good universal health coverage, both in terms of service package, financial protection, and we also even cover migrant worker and foreigner come to. We cover everyone on Thai soil. So that is in the principle. We are quite proud of that. We have innovative financing for health promotion, which come from the so-called syntax 2% surcharge of tobacco and alcohol. So that let me come back to that point later on about innovative financing. But to fund health promotion later on, we have a good practice on this syntax in Philippines, in Laos, in Mongolia, and many other. We have a good social participation in terms of National Health Assembly, which is the mass gathering every year, where people of all walks of life come to discuss health and well-being issues, together with government, with politics, with knowledge and social sector come together. So that is a good foundation that we are quite proud of. But when in 2018, when we have the UN Interagency Task Force, also led by Nick, come to Thailand, we realized that our strength cannot much address the issue of NCD tsunami, or previously we call NCD pandemic in Thailand, because we have three bottleneck factors. The one is that it has limited cross-sectoral coordination, the real accountability, engagement, and ownership, in particularly beyond health sector, which lead to the uneven progress in terms of NCD prevention and control. We have quite good in terms of individual target intervention, screening, treat. We have seen the sharpshooting in terms of effective coverage of hypertension, diabetes, and many other. But we are quite slow progress in other sector. So that is first bottleneck. Second, we have a rampant issue of commercial determinant of health. We have seen the issue of industry interference, which is big and slow the progress in terms of NCD prevention control. And third, we have the issue of implementation and enforcement. We have good policy in paper. If you have a checkbox in terms of policy content, we are quite good. We are one of the world leader in that sense, but not implement. Policy is as good as it's implement. We know this one. And these three challenges has very much affected by this COVID-19 pandemic. I totally support that we need to, it is about how. I'm thinking about firstly to reframe about the key population as discussed by many, including Cecilia. We have seen the sharp shooting in terms of mental health issue in this COVID-19 pandemic. We have seen the sharp shooting in terms of malnutrition, which is we are quite proud of, used to be proud of in this reduce the curve of malnutrition, but now it is triple malnutrition, under malnutrition, over obesity, and micronutrient malnutrition. We have seen all. My kids rely on all this instant noodle almost every day during the lockdown. And we know that this is not nutritious enough. The second, apart from reframe the key population, we need to redefine health security. And I look back at why we start the international health regulation on health security. We talk about security as the vulnerability to health risks. And I had no doubt that we have too many NCD risk factors that should be defined as health security as well. Even it is slow in progress, it needs lag time. And third, we need to refocus on the goal. If you talk to those pandemic response and preparedness people, they are focused on infected case. They want to about the COVID death. But if we refocus on excess mortality for overall, not only COVID-19, as Tom rightly said, that this is the real issue. When we talk about COVID-19 response, we talk about infection, we talk about control, we talk about home isolation, community isolation, but we close our eye on the excess death from NCD. It is sharp rising, partly from the disruption of service. We talk about, rightly talk about mental health issue. We have seen an increase in terms of suicide case here. If we refocus this spotlight of goal from case only to excess mortality, we can frame the more comprehensive framework to work between these two tsunami, NCD and COVID-19. But most of all, Tom also rightly point out that the COVID-19 hampered the issue of NCD people. We know this very well, chronic underfunding issue of NCD prevention and control. Only 2% normally before COVID-19, only 2% of overseas development fund go to NCD. But we have 70% of burden of disease. This is the what you call the Jack and the Giant. 2% to fight for 70% of burden. And this COVID-19 even hamper it further. I'm not talking about mental health, which is less than 0.5%. So we need to relook at this overseas financial issue as well. But let the country let domestic resource mobilization. That is the main engine for the long run. I stop here. Thank you very much.
Thanks, Dr. Thasapon. Nick, I was wondering if you wanted to step in at this point in time to pull out the 4 or 5 key messages that we need to bear in mind from the perspective of the UN. So over to you, Nick.
Okay, thanks very much indeed. Some really rich comments and some themes coming through here at the moment. I mean, clearly Tom articulated the scale of NCDs, this unhealthy feedback loop, this vicious cycle that's working both ways. Raji re-emphasized that vicious cycle, as did Mek and everybody else. So there's clearly that going on at the moment. And please, everyone be aware that Tom shared an important link in the chat. The next thing that we've really heard is this issue around service delivery. Raji emphasized that again and again. Cecilia called upon that, and again, John and Mek, particularly at the country level, emphasized that away. The third thing that we've really heard has been about resources. Now, Raji emphasized that there has been a shift in resources away from NCDs. He's seen that at the moment. Most of the panelists have highlighted the fact that actually resources need to be considered and directed towards this at-risk group NCD. But both John Arne and Mek both very clearly said it's really important not to usurp domestic mobilization responses, not to crowd out domestic financing. I think that's the term that John Arne used, or to undermine national governance or responses. You know, when we talk about financing, Mek very clearly talked a bit about examples of innovative financing and health taxes. So I think that's really important. You know, Mek, you were very clear and you were very honest in your presentation, both at the national level, in terms of talking about policies are only as good as their implementation and their enforcement, and the importance of and the challenge of tackling commercial determinants of health and multi-sectoral responses. So that was really important hearing that. I also thought you were very honest at the family level, talking about the challenge in your kids not eating too many pot noodles. So I think that that was really helpful, and that then brought me back to John Arne's comments, where he was talking about the importance of building capacity for the prevention and control as part of preparedness. So tackling some of those issues that Mek has described, and the challenge of, you know, exactly how to do that. Yes, external funding, but not in a way, as I said, that crowds out domestic financing. But that NCD should certainly be part of the pandemic preparedness now and in the future. The way that I want to conclude this summing up is by reflecting on some of Cecilia's comments, because Cecilia, you talked about the importance of browbeating and advocacy, and I think that's a really important issue for you know, the UN system to provide support for advocacy, yes, for technical assistance as well, for coordination, bringing people together. But I did think the browbeating and the experience of HIV is important. And although we all recognize the importance of the links between NCDs and COVID-19, it's quite clear that many people still don't do that. And again, coming back to Mek's 2% for 70%, which I think is a great strap line, that we're nowhere near that. I think the importance of the social, legal and cultural barriers is important. Again, a big role for the UN there. And then thinking a bit about key populations and what that means from the perspective of the Global Fund and how that can be used to frame NCDs. And that if we think that we're at a pivotal moment for NCDs, we could try to start sharing this terminology. Yes, there are inherent challenges in doing that, and you outline what those are, but also opportunities to start to have greater integration and to pivot the NCD response. So maybe key populations could be a useful framing, because it would, as you described, help articulate the need to increase access to treatment, issues around human rights and equity. So I'll stop my summary there, Gita.
Thanks a lot, Nick. Very, very comprehensively pulled together. We've got 8 minutes for a second round of questions. Before we get into our second round of questions, I want to encourage all participants that are there for this session today to use the chat function to share with us any thoughts, any questions that you may have for a panelist. That is going to make the whole discussion much more lively and interactive. So feel free to use the chat function and share thoughts and questions for our panelists. While you are typing in the chat box, let's move on to a second round of questions. And this time I want to start the second round with Dr. Thasapon. Dr. Thasapon, and this is about, you know, we know Thailand is the founding strategic partner for the UN Multi-Partner Trust Fund for NCDs and mental health. What do you see as the added value that such a trust fund can provide to countries in these challenging times? Over to you, Dr. Thasapon.
Thank you, Gita, for that question. So yes, we are the strategic founding member of this multi-partner trust fund. This does not come by chance. We have a great many rounds of extensive consultation with domestic partner and also the international agency altogether. Why we focus on this one? Because we think about this Mptf can be the game changer, not to Thailand, but regional and the whole world. I'm not talking about adding just another dollar to the game. If we change from 2% to 2.5%, that doesn't change the whole game. But we see this one as a strategic catalyzer to the game. We agree that this the NCD prevention and control has to be led by country, mainly funded by domestic resource. And let me put this analogy. This is just like the car. This is the main petrol to the car. Why this Mptf is the lubricant. How we can use this small portion, much small portion, to make much bigger portion of this budget resource more efficient. And we have seen that one. So this is just like this model. And when see this is when we talk about fund, people talk about dollar. But no, we do not see this fund as the only dollar, because it comes with partner, it comes with actors, and this partner, this actor, being their own expertise, their own assets, including networking. WHO is very good in convening, in reaching the best brain in the world. UNDP is very proficient in terms of making economic argument to those outside health sector. So dollar is just a platform or a medium to bring this collective capacity. We want to also increase this our collective capacity, not aiming to use this multi-partner trust fund as the main engine. That is the first wrong point. If we start using this one to fund mainly service to people, this is just like drop of the water on the desert. This is nothing. But if we wisely use this small money to improve the routine work, to make the country better capacity, more efficient, that would be the game. But how to spend this one? Firstly, I think we need a good strategy for this quality spending. Flexible enough, country-led. We should talk about seeding fund, matching fund. We should talk about strengthening the information system as a leverage to bring more domestic resource, domestic capacity, to strengthen domestic infrastructure for NCD and promote this ownership of particularly outside health sector. Based on share trust, share goal. So I think this an agree framework. We have already agreed framework. One of the including the UNGA high level political declaration. So that is clear to us. So with that I reveal our thinking behind why Thailand joined this Mptf. Over to you, Gita.
Thank you, Dr. Thasapon. Let's move on to John Arne. John Arne is the Norwegian ambassador for global health. Can you share with us the top kind of 2 or 3 measures that Norway has adopted for NCDs when it comes to COVID-19 and the pandemic preparedness response strategy?
Yeah, thank you. I think I would first actually, I like the metaphor on the car. And the point that the main mechanisms to make the car moving forward, either being petrol or now more and more electricity, I hope, in a sustainable future. But that being domestic responsibilities, domestic resources, and what we cannot do externally from international support is actually more of a lubricant. So one I think the big point then is, where are we driving this car? And I would like to take that as a starting point, because the main goal for us to drive this car is, of course, to achieve the SDG 3, because that's a holistic health goal. It's about reducing all diseases, and we cannot. And I guess my point of making that point in a way is that we cannot have lubricants for all different diseases and mechanisms, risk factors, and so forth. And there is a tendency in the health space, in particular in the international part of the health space, that we have individual organizations that are providing specific lubricants for the system instead of more holistic lubricants that make sure that we can drive smoothly towards the goal. Having said that, and that comes to your question, Gita, because we saw in our strategy and our priorities, there was a huge gap, and it is indeed related to the fact that NCDs are contributing to the largest part of the disease burden internationally, and the mechanisms that we are using have not taken that into account. So we developed in Norway, and actually I think we are the first donor country to develop a national strategy on how to actually include the NCD issues into a holistic health development strategy. And there we have 3 clear goals. We need to strengthen health systems in low-income countries. We need to prevent and reduce risks through multi-sectoral measures, and we need to increase the ability of the system through access to health data and health information to actually deliver better. And last year, we developed sort of from this strategy, we've made a NCD development program where we aim to assist low-income countries to ensure quality health facilities that can offer adequate NCD services, including for mental health disorders. And this is also important, definitely now in a post-pandemic recovery context. Another aim of the NCD development program is to work with other sectors to prevent NCDs, or NCD risks rather, from unhealthy diets, air pollution, tobacco, and harmful use of alcohol, and very much in line with what Mek just mentioned on how you could do that, and also how to link that to potential taxation. And we will definitely, as Norwegian government, continue these efforts in 2022. The World Health Organization has been our main partner, and our support will enable effective collaboration with governments in low-income countries on reducing premature deaths from NCDs and promote healthy lives. But with definitely a lubricant perspective, because the most important message is that this needs to be a priority of health ministers. It needs to be a clear pathway towards the reaching the Abuja target or other domestic health financing targets, that we need to have an integrated approach to meeting and achieving the SDG 3. Thank you.
Thanks, John Arnie. And I wanted to go back to this whole question on domestic financing. Thailand, in many ways, has shown pathways in the context of COP26 and climate financing, how they've brought on board bankers and investors and the private sector to finance the green economy and finance clean technology in many ways, and very innovative financing mechanisms. My own sense is that in upper middle income countries where you've got a rather robust private sector, we need to bring the private sector on board to create those innovative financing systems to support the whole, to support financing of NCDs, where we see the burden of NCDs increasing, especially in the context of COVID-19. And I'm sure this is an area that Thailand probably could contribute in the future. But let's move on. We've got a question from James Reed, who's asking us to speak to how the Mptf will link with or coordinate with similar initiatives like the NCD Trust Fund being advanced by the World Bank. And I want to check in with Tom. Tom, do you think you will be able to speak to this particular question that has been raised by James Reed?
I don't think I'd be the best person to speak to that particular question. I can talk
No
about
worries,
financing in general, but I suspect Nick or Momka or others would be more knowledgeable on the links.
Okay. Thanks, Tom. But Tom, just moving on to a question that we wanted you to focus on. We were wondering if you could talk a little about, in the context of the global financing for PPRs, what, according to you, holds the most promise for supporting countries to step up action to tackle NCDs? Within the framework of the larger financing for NCDs.
Great, thank you so much. So I want to make a few points here, and this ties a little bit to what John Arnott was saying before. This is actually going to be a difficult global health financing environment. There are a lot of initiatives looking for financing at the same time. A global fund is seeking replenishment, Act A is seeking a significant amount of funding, COVAX is seeking a significant amount of funding. All this is happening at the same time, and some of these initiatives are going to be quite competitive with one another, given the limited financing. So that's point one. The second point is every global health cause will seek to bootstrap this pandemic, about how their particular pre-existing issues should be the focus of pandemic preparedness moving forward. The third is that countries, the pocketbook is closing. Unfortunately, countries have dealt with the economic hangover of this pandemic and are becoming less willing to spend instead of more willing to spend at this point in the pandemic. That's shouldn't be true, but unfortunately it is. So how does this tie to what this means for NCDs from my perspective? I really liked, not to cite the same speaker again, but I like John Arne's point about looking at specifically the links between a health priority and infections, severe health outcomes, and third, the broader impacts of non-pharmaceutical intervention, so the social consequences. NCDs has a very strong case, certainly on the latter two, much stronger than many other priorities, health priorities. It is very important to be targeted in making it. So instead of recycling our best buys, to be very specific about how NCDs links to these particular elements of pandemic preparedness. I actually think NCDs also has a reasonable case on the link to infections because of immunocompromised people and the settings in which NCDs, people being more likely to be in care settings, and some which are to some degree a greater risk in a pandemic. There is a tie there to be made, but it's going to be very important in this difficult fundraising environment where you have so many causes seeking funding in connection to pandemic preparedness to be very targeted in what we put forward and be very evidence-based. I do think there's an opportunity to do that potentially in what's going through in terms of this G20 task force that may be looking at financing in the different buckets there. But again, we can really distinguish ourselves as a field by being targeted and prioritized and evidence-based.
Thanks, Tom. Very, very helpful. At this point in time, I'm going to request Nick to step in. Nick, do you want to take a stab at the question that James Reed has posed to us?
Yeah, I'm very happy to start off. And then as Thomas said, either Linda or Mamka may wish to come in as well. These are both, the question was, can you speak on how the multi-partner trust fund will link or coordinate with similar initiatives like the NCD Trust Fund being advanced by the World Bank? These are, as well as others, are emerging issues. So there are emerging discussions. The first and most important thing to say is that the bank and the Multi-Partner Trust Fund Secretary are in very regular contact to make sure that there is good discussion and good understanding of the value added and the difference between these. The Multi-Partner Trust Fund really is around catalyzing action, catalyzing domestic action and domestic financing. So it's taking small amounts of financing and then trying to leverage domestic resources and domestic action for greater good. Yes, we are at the time of the pandemic, but the Multi-Partner Trust Fund was considered well before the pandemic, and it was established, yes, during this time, during the time of COVID-19. But actually, the NCD epidemic is not, or pandemic is not going to be going away. And so trying to catalyze domestic preventive responses at this stage and for the foreseeable future is crucial. There are a number of mechanisms that will be out there which will be trying to encourage this move away from 2% to something much more significant, to the 70% that Mek was talking around, whether it's the bank, whether it's the UN-led multi-partner trust fund, whether it's the global fund, and trying to encourage ever greater attention to the comorbidities and co-infection activities, or indeed domestic financing, which both Mek and John Arne pointed to earlier. So it's not a binary choice. It's not one versus the other, but it's a number of different initiatives, each of which will have their own places and added value, and different international financiers will be interested in supporting. But let me ask if either my colleagues from the Multi-Partner Trust Fund Secretariat, Linda or Mamka, want to come in and supplement or complement what I've just said.
Not on my end. I think you have it covered. Thanks, Nick.
Okay, back to you, Geeta.
Thanks, Nick. Let's move on. I wanted to invite Cecilia to step in now. You know, Cecilia, from you know, how you frame the key population groups, the framing that you did of key population groups. What are the tools and resources that are potentially available to government to integrate NCDs into the domestic PPR agenda?
I needed to unmute myself. Thank you, Geeta. Like my earlier caveat, this is probably not my area of expertise, but I would have thought that tools that are already available from the WHO Best Buys and also the WHO Framework Convention on Tobacco Control would have significant roles to play in terms of providing the tools for governments to integrate NCDs into a domestic PPR agenda. I think there are also different ways of looking at tools, and I think, you know, previous speakers in the discussion already have talked about the fact that we need to be looking at broader issues, and for this, other agendas that are relevant to both NCDs and pandemic preparedness and response includes issues, obviously, of health system strengthening, as well as climate change, not to mention the SDGs. So I think there, you know, there's already been mentioned that the Global Fund strategy of, I think it's 2023 to 28, really does emphasize that there is a need to contribute to pandemic preparedness and response by looking at you know, integrated systems for health. So I would think that these are sort of the key tools that would be necessary to look into you know, sort of integrating NCDs into the PPR agenda. And then I guess the other thing that, you know, might come up is whether or not, you know, the ongoing pandemic treaty discussions would, you know, look at how NCDs can be effectively integrated. And in doing so, this might then have the force of looking at these issues from a domestic level as well. So let me stop here. I think you're muted, Geeta.
Yeah. Just as a quick follow-on question, are there any examples of good practice that may be emerging from either Asia or Africa or any other part of the world on you know, on the key population groups vis-a-vis NCDs? Is there any good practice that you've come across?
This might be a question that I would ask my colleagues to help me on. I'm not as clear that there are already sort of good practices. I do know that there are, sort of practice and policies around the use of key POPs aside from HIV. As I mentioned before, in terms of TB and malaria, there is already, sort of looking, a discussion and implementation of key populations across these diseases. So I think there is an opportunity for incorporating NCDs or incorporating the key population framing within in NCDs.
Thanks, Cecilia. Let's move on to Dr. Raji. Dr. Raji, what needs to change in the current international financing landscape to address the need for tackling NCDs as part of the pandemic preparedness response agenda?
Thank you so much, Ijita. Let me start from the issue of health security and the national system that my colleague from Thailand eloquently talked about. I completely agree with him that this is a time that we need to begin to decentralize that multilateral architecture that is looking at health security. I'll come to finance much later on. One thing that we're beginning to see as far as this pandemic is concerned is the collapse of that multilateral architecture. And we have now seen that the regional approach seems to have worked very well, if not anywhere, especially in Africa. We have seen the role played by African Union in coming together, bringing 55 member states and bringing 1.3 billion people together in a very coordinated and collaborative manner. And as a continent, we have been able to work as a bloc, and respond to this pandemic. Let me give you one example in there. You see, at the outset of this pandemic, the issue of our medical supply was a big, a problem for everybody, including things as simple as masks, PPE, and so on and so forth. And under the leadership of our head of state and government, the former chairperson, that's Cyril Ramaphosa, we put in place what we call the African Medical Supply Platform. And with that platform, we're able to ensure that each and every member state, irrespective of the ability to pay, we're able to have equitable and affordable access to those essential medical supplies. We moved from there, we have applied the same principle to vaccine, and it seems to be working. So I think as much as possible, the multilateral mechanism is fine and good, but we need to begin to listen to the regional voices as well. And what we have done in that regard as Africa CDC is to make sure that that coordination mechanism under the leadership of our head of state and government continue to provide the needed, guidance as far as responding to this COVID-19 pandemic is concerned. And at the national level, we continue to support each and every member state to have what we call a National Public Health Institute. That's the US CDC equivalent, the Public Health England equivalent in each and every member state. Because this is the only way we think we should be able to guarantee our health security going forward. Now, in terms of financing, I think this is one area, again, where we need the regional voices as well. As one of the speakers rightly mentioned, we've seen a lot of funds coming in, but there is no coordination. World Bank is providing some funds, Global Fund is providing its own, we have bilateral mechanism providing their own, and at the end of the day, the effect there, in fact, some members don't even know how to access some of these funds. Some members don't even know whether this is a grant, whether this is a loan, or what is it, they don't know. So I think as much as possible, we know that a lot of funds are coming in. It's just like you have too many good people moving around. At the end of the day, nothing will happen if there is no coordination. So I think as much as possible, we welcome, this multiple sources of funding, but we need coordination. And I think the best way to coordinate these things is to ensure that those regional mechanisms, the regional platforms, like the African Union, the Africa CDC, that has been put in place, and, and enjoy a lot of political support. Let me emphasize that, political support, because the Africa CDC since the onset of this pandemic, has had that privilege of briefing the head of state and government 16 different times. I'm not sure there's any other regional health organization that enjoyed that much political support. I think this is one of the reasons why we've achieved so much success on the continent of Africa. So I think going forward, the funding is there, coming through a lot of mechanisms, but what is lacking is that coordination, that collaboration. Secondly, on our own within the continent, we will continue to mobilize resources domestically. And one of the head of state has been in charge of this even before the COVID-19 pandemic. That's President Paul Kagame of Rwanda. And since the onset of the COVID-19 pandemic, we're able to put together what we call the COVID-19 fund. And each or most of those rich countries on the continent of Africa were able to put a lot of money in there to support those member states who are, I don't know how to describe them, but those ones who are not that adequately resourced, to support them in terms of this COVID-19 pandemic. The other thing we have been able to do on the content again is to leverage on the platform resources at the disposal of the private sector. So from day one, the private sector has been part and parcel of this response, and they've put all their resources at our disposal, from technology, the digital platform, financial resources, technical expertise, and so on and so forth. We have also put in place a mechanism that will allow us to attract funding from traditional and non-traditional sources, the African Public Health Foundation. So that on its own has also supported a lot of member states. In fact, for the African Cup of Nations that is coming on now, the resources that will be supporting the COVID-19 arm of that, Cup of Nations is through resources from the Africa Public Health Foundation. So we have been able to do, to get all this support. So in terms of NCDs, I think for us at Africa CDC, we want to see the NCD integrated within the larger primary healthcare system, so that we are not looking at it in isolation. We want to see it captured as part and parcel of the primary healthcare system. I also want to see in the medium to long term for each and every of our member states to have what we call the NCD toolkit, in the context of public health emergency. One of our colleagues on the panel mentioned the fact that we have to begin to look at NCD as part and parcel of emergency preparedness and response. We need to have a pillar that should be focusing on that. And for us as Africa CDC, we'll be supporting the development of a toolkit, that will allow us to be able to manage NCDs within the context of any epidemic or pandemic outbreak. To summarize, for us at Africa CDC, we believe that to come out of this pandemic better, stronger, and bolder, we need a forward-looking strategy that will be inclusive of NCDs and mental health. And this is going to be underpinned by 4 key pillars. Number 1, to strengthen our public health institutions, so that in addition to responding to whatever epidemic that is out there, those NCDs, those essential health services will also continue to be supported. Number 2, adaptive health workforce development. Very, very important. And we want to see NCD as a track within the field epidemiology and lab training program, so that we don't get this, we don't take our eyes off NCDs in the course of any pandemic. Number 3, air security commodities. We need to begin to build our local manufacturing capacity for air security commodities. Things as small as diagnostics, so that we're able to diagnose whatever that is, in addition to the pandemic, the NCDs, and so on and so forth. Vaccines, very, very important. Therapeutics, PPE, and all those consumables. Then the 4th pillar in there, which ties to what we are doing here today, is that of respected and action-oriented partnership. Something that will bring all the partners together in a very coordinated, respectful and action-oriented manner. Thank you. Over to Jita.
Thank you, Dr. Raji. I liked your 4 points that you set out. Strengthening public health institutions, adaptive health force development, local manufacturing capacity, and action-oriented partnerships. Very, very nicely summarized. Now, before we bring this session to a close, I wanted to offer an opportunity to each of our panelists for any final thoughts that you might want to share with the participants today. would any of you want to, step in with your final kind of thoughts? This is your, Tom, would you want to come in with any final thoughts?
I can. I will be largely repeating myself, though. So what I will say is, again, this is the time to be thinking about these issues, both in the current pandemic and moving forward. NCDs as a field or as a subfield of global health really are in a position where there's incredibly strong evidence. We shouldn't be shy about it. We really need to take that forward and reassess how we think about pandemic preparedness and response in the future. So I'm happy to play my part in that and hope everyone else on this call will do the same.
Thanks, Tom. John, Arnie, would you want to step in with any closing kind of remarks?
I liked Raji's summary points, the 4 points, and if we take the last one in a way, respectful, action-oriented partnership, I guess my best advice would be to try to drive this from the country level up in a way, so make sure that the policymakers, the decision makers across government ministries understand the needs to invest in NCD prevention and care, of course, and treatment. It's a good buy. It has a huge development impact in general, but the priorities need to be set by countries and country leaders. They need to demonstrate by national priorities, I think, domestic investments, and then push the maybe more decentralized multilateral system that we can also be an ambition would be able to respond. I think there is a big dilemma because I also very much acknowledge Tom's point that we have the evidence and we need to be specific. But the challenge, if we do fundraising based on specificities, we get a very sort of disaggregated and heterogeneous and complex financial environment. So how could we sort of make the narrative, the cases based on specific strong evidence and cases, but try to avoid complicating the institutional landscape, because we rather need simplification, as we also heard from Raji, when it comes to country experiences of having many international partners coming in with different, all wanting to do good, but with different requirements and needs. And I think this is, everyone agree, it's so hard to do something about. So how can we do something about this?
Thank you, Jonani. Your point about it being country and ensuring that we have a more decentralized multilateral system as we deal with these challenges is bang on. It's something that probably will figure as one of the key messages that the UN Interagency Task Force pulls together towards the end of the session. But would Cecilia, would you want to come in with any kind of final half-a-minute remark?
In half a minute. Sure. I think I was struck by John Arna's comment about, obviously, it is very important to have country-led initiatives and, prioritization and all of that, including domestic resource allocation. But I think, if we're dealing with NCDs in the context of PPR, then we probably need to be looking at, a global response and some sort of global public goods, because at the end of the day, if we're talking about, global health systems and health security, we need to ensure that that's taken into account, and whether that's going to be part of the treaty negotiations or whether that's going to be, a much more ramped up approach from the UN Interagency Task Force, I don't have the answer, but I think there's got to be a real balance between, what is seen as country-led efforts, but that has to be supplemented and complemented by a global level response. And I think in this case, the UN agencies probably have, a role to play, as with the regional institutions.
Thanks, Cecilia. Dr. Pasapon, half a minute. Any final kind of remarks.
Thank you. Thank you. I totally agree that we have to strike a balance between the national and supranational level. I'm totally okay about the global public goods and to guide country, to support country to do to share the good practice and guide the country decision. But we also need action on the ground. Success of this Mptf is not what we do, but what we build, I would say. I focus on capacity, in particularly on two things. One is networking, and secondly, is about accountability framework. I still don't have the clear answer, but I think that this is the need. If we can hold actors at national level, at local level, and region and global level to account, this can be a game changer. But we also need a good monitoring, review, and action in terms of audit and review as a learning community. Over to you. Thank you.
Thank you, Dr. Thasapon. And I like the point that you make about balance between national and global level responses combined with action at the country level. It sits very well with the 4 points that Dr. Raji had pulled together. But let me at this point request Nick to step in. Nick, do you want to help us, add on to the 4 or 5 key messages that you had pulled together initially? Are there any other messages that you want us to, that you take note of at this stage?
Well, there are a number of key issues that have come in the second round of discussion. I mean, in the interest of time, I'm not going to go through them, but what I'd like to reassure people is that our intention is to produce a short summary note of this meeting, which we would, between Geeta and myself, like to share with the panelists to make sure that they're comfortable with what's been said, and then share this with all of you and have on public record, because some of these really important points that have been highlighted. Clearly, none of this is easy and straightforward, and we've heard very clearly about some of the issues around countries now pulling in their resources as a result of the pandemic, and we have to understand that this is going to be an inevitable consequence of where we are. I'd just like to reflect on one chat that has not been reflected, and that was a cri de coeur from Joyce Natu in Kenya, talking about the lack of human resource costs that are being that are being mobilized at UN and country level. And of course, as people have said, it's at the country level that this rubber hits the road, so to speak. And I guess that she says, as we prioritize prevention and control, the issue is that at the moment, I don't believe we are really prioritizing prevention and control. And I think while everyone talks about it, and Joyce talks about it, saying that WHO, as an example, highlights the importance, we're not really moving this agenda forward. And I have to come back yet again to Mek's comment about 2% for 70%. So if I'm going to leave you with one thought, it's going to be about trying to improve that 2% for 70%, directed at the country in a way that, as John Arne says, doesn't complicate the international architecture.
Thanks, Nick. So let's pull the session. Let's attempt to close the session today. Let me thank our panelists for sharing your perspective with us. Very, very helpful, and Nick will definitely take that on board. I also wanted to thank Linda and Mamka for doing the back-end work to make the session possible. This wouldn't have been possible without the hard work that both of them put in over the Christmas and the New Year break, right? So thank you, Linda and Mamka, for making this possible. Thank you to our participants for actively being engaged in this discussion today. And thanks, Nick, for agreeing to co-moderate today's session with us. We look forward to sharing the key messages that Nick and the team pulled together with all of you, and hopefully using that as key advocacy messages that we will carry through over the coming year as we hopefully secure funding for the UN Multi-Partner Trust Fund for NCDs and mental health. So thank you all, and enjoy your evening. Khap khun khap.
Great. Thank you, everyone. I'll close the session. Thank you.